before we start talking about updating you on our current clinical activities, I do want to take a moment to remind you of our unified approach to developing regimens for both drug-sensitive and drug-resistant TB. So we all know that the current approach for developing drugs for MDR is to add a single agent to the existing standard of care regimen. These regimens are already complex. Adding additional drugs makes them more complex, and studying them requires a long period of treatment and a long follow-up duration. However, the greater unmet need per patient because of MDR and XDR really has accelerated the need for new treatments and has led to accelerated approvals. These accelerated approvals, although they do provide medication earlier to patients, they leave us with a number of questions after the development. We don't really know how to use the drugs, how long to treat, and we still have to perform phase 3 studies. Combine that with the fact that if you have a medication that you're studying in MDR, you have to do a separate treatment program for sensitive TB, you end up with really quite a complicated development program. And we'd like to propose that, in fact, there's another way to do this. And that is that by studying drug-sensitive and drug-resistant disease at the same time, you can shorten the development program and provide for greater data at the time of registration. Remember, if you study MDR using the current standard of care control group, you really end up with a lengthy, difficult, toxicity-prone, and really a program that really is expensive and not terribly efficacious based upon the current standard of care. However, studying any clinical study that uses the current standard of care for MDR as a control really gives you, a 24-month endpoint, which is really quite difficult. So we believe that patients should be treated based upon medications that they're sensitive to rather than those that they're resistant to. And so, we think that using the term MDR really in the context of drugs that have really no resistance that exists, really it just doesn't apply. So the goal of this program is a proposed indication where drugs X, Y, and Z in combination are indicated for the treatment of tuberculosis caused by strains that are sensitive to those drugs. So in studying both sensitive and resistant patients at the same time, only patients that are sensitive to these drugs would be included. And traditional labels such as MDR or XDR or drug sensitive would not really be part of the inclusion or exclusion criteria. So this is a very complicated slide, and we won't go through all the details, but just to sort of highlight how we see this working, preclinical and phase 1 development of drugs really would proceed the way you typically would. You would do your standard preclinical mouse models. You would be looking for both the effect of drugs as monotherapy as well as in combinations. Phase 1 would be a standard phase 1 program looking for pharmacokinetic and safety data in normal healthy volunteers. And then as you move into phase 2, you can consider combining drug-sensitive and drug-resistant patients in the same study. We would still be doing single drug monotherapy dose-ranging studies, and we'd also be looking at combination therapy studies in drug-sensitive patients. But as you began to gain more experience with the drug in regimens, you could consider including patients who would classically be called MDR, but do not have any resistance to the drugs in the combination. Once you've established the efficacy in a 2-month study, you could then go into a phase 3 study that would do the same thing. The idea here is that the comparison would be drug-sensitive patients versus standard of care, HRZE, and your drug-resistant population would be treated in the same way, and they would be really you would confirm the effects in MDR patients for really consistency with what you're seeing in drug-sensitive patients. So now to move on to what we're actually planning on doing and doing currently at the TB Alliance, I want to talk to you a little bit about this idea that we have, this proposed collaborative rescue, or we've even heard people call it a salvage study. But really what it is we're calling it the New Chemical Entities in XDR-TB study, or NICS-TB. And the idea is that although drug-sensitive and even MDR-TB are both curable diseases, given enough resources and time, XDR and TDR patients really have very limited treatment options, and their outcomes are really quite horrible. These are desperate patients. We also know that optimal therapy for these patients would really consist of at least 3 drugs to which their MTB is susceptible. We also know that new chemical entities without any pre-existing resistance are being developed and will be available relatively soon. So the aim of this program is to help patients with XDR-TB now under carefully controlled clinical study conditions, and at the same time we can learn something about how these drugs work in these patients. So the proposal is to approach all the partners who have drugs available for whom we'll have at least 2-month data that would allow us to consider combining them into regimens that might be effective in XDR. We have a number of drugs that could have promising data by the end of next year. They're listed here, you know them, we've been talking about them for the last 2 days. And the proposal is to initiate a global study of these combinations of new drugs in patients with XDR-TB, collaborating with all the partners who currently are developing these drugs. Once the collaborators have committed and we have a pool of drugs to look at, we would do the standard mouse studies looking at their effectiveness in terms of treatment duration. And some of those studies are actually ongoing already, so we would have the data relatively soon. And then we could sort of provide patients with XDR with a complete regimen that would allow us to treat them in the context of a clinical study without developing resistance to the new drugs. A couple of things to point out is that this is really a clinical study. It's not intended to be compassionate use. The idea is not to treat MDR-TB or to expand the access to these drugs beyond XDR. It really is intended to be a classic clinical study, although done in a way in which it's sort of a small, highly controlled study, but that's relatively easy to implement and clinical sites that treat patients with XDR. So with that, I'll turn over to my colleague Dan, who will talk to you about some other activities.
Thanks, Steve. It's been really exciting over the last year to work with ongoing clinical studies evaluating a number of new regimens and combinations put together. Last year at this meeting, Carl gave a preview of the early results of our new combination 001 study. And at the beginning of the session, my colleague Martin Springsley from Bayer reviewed some of the key findings of that, which were published in The Lancet this summer. Just as a reminder, a couple of key things we found there. And now these were studying drugs that we knew individually did have bactericidal effects over 14 days in an EBA study. We were looking at them in combinations, and we did find that pyrazinamide added to either bedaquiline, formerly TMC-207, or added to PA824 had substantially greater effects than the bactericidal activity over 14 days of those drugs individually. So that was important to understand that as building blocks, those 2 drug combinations. But then the key was the 3-drug combination PA824, our nitroimidazole, with moxifloxacin and pyrazinamide. The 3 together had a very substantially larger effect in reduction in colony counts, or a very similar effect in time to positivity and liquid detection, liquid culture detection, as compared to the standard 4-drug HRZE regimen or any of the 2-drug combinations. So taking that, we moved ahead into our new combination, NC002 study, and Martin gave you a preview of that, and let me just show you a little bit more. This is the design of this, which really flows from our unified pathway that Steve just showed you. about. So we are including both drug-sensitive and drug-resistant by traditional criteria subjects into the study. Drug-sensitive subjects are randomized to 3 arms, either the comparison Rifafor, which is the brand of HRZE used in South Africa. We're using it actually, South Africa, Tanzania, and Brazil are the 3 countries of this study. And then PA24, either at the 100 or the 200 milligram dose. Just as an aside, those doses did not differentiate in the 14-day EBA study, and we recognize that we still need to explore this in a later study with moxifloxacin and pyrazinamide given at a fixed 1,500 milligram dose, not weight-banded. What's exciting about this study is that in all of the arms, 15 subjects are inpatients in a very formal traditional EBA study, and then all subjects, both the EBA and the non-EBA subjects, are followed for a full 2 months with serial sputum counts done and time to positivity and liquid culture in the midget. Now, subjects that on screening are found to be resistant to moxifloxacin or INH and rifampin, of course, are not randomized to the HRZE control, but they are given open label PA24 at 200 milligrams and the moxifloxacin and pyrazinamide. And they have several different tests done to assure that they are not resistant to moxifloxacin or pyrazinamide, and then followed for 2 months. So a couple of exciting things that are unique to this study that are both challenges and opportunities are on the next slide. Some different first. So it's taking a novel regimen from 2 weeks into 2 months. What we expect to show, but want to show, is that the EBA reductions in colony counts continue relatively consistently through the full two months. That remains to be seen. We are enrolling drug-sensitive and drug-resistance into a single trial treated with the same regimen. So this moves to our new paradigm of the unified pathway. So we are treating patients not just resistant to INH and rifampicin, but who are sensitive to moxifloxacin and pyrazinamide, and the assumption is, of course, that they're all sensitive to PA24. We also, this will be one of the first EBA studies to ever truly enroll multi-drug resistant patients. So it will be very important to see, do drug-resistant patients and drug-sensitive patients treated with the same regimen perform the same over the course of the 2 weeks of the EBA study or the full two months. This also is the first study to evaluate pyrazinamide in a fixed dose. The 1,500 milligram dose was carefully derived from very complex modeling done, looking at where we could optimize both efficacy and safety. And then another first for this is we actually, when everyone's on board, will have 5 mycobacteriology laboratories doing quantitative counts and the time to positivity in the midget. Let me just move on. Our other novel combination study is our new combination 003 study. This is a 7-arm study, and the first patient actually is undergoing screening as we speak. So the study has started. It's being conducted at 2 sites in Cape Town, South Africa. It's a fairly traditional 14-day EBA study, which will include both quantitative colony counts and the time to positivity and liquid culture in the midget. We are including, to better scientifically understand, pyrazinamide alone. While EBA studies have been done with pyrazinamide, the last really 14-day EBA study was done, many years ago, and we actually don't have liquid culture time to positivity in a study like this. So we're studying pyrazinamide alone. This will be the first true EBA study of clofazimine. As you all know, clofazimine has become popularized somewhat by particularly the publication of the so-called Bangladesh regimen, Dr. Van Doon. and is being used around the world with some good preclinical evidence. But in a sense, clofazimine has skipped all the other development steps that normally take place. So this gives us a chance to look at, does it or does it not show bactericidal activity in the first 14 days? We also have very intensive ECG monitoring. We are doing triplicate ECGs at multiple time points, both at baseline before dosing and 3 times during the day for a number of days during the study to look at it very carefully. Then we include multiple regimens, which could be ultimate final regimens. So J is for Janssen, bedaquiline. We're not quite sure if it should be J or B. I'm not sure our colleagues at Janssen have that pinned down yet, with clofazimine, pyrazinamide, and PA24 in all the various combinations, as you can see. So the exciting thing here is it includes 3 drugs that don't have any pre-existing resistance, plus minus pyrazinamide. Very exciting to have this under enrollment right now. We expect top-line results next fall, around October, and based on the results, we'll move forward with subsequent studies. Let me just finish, last slide, with just a reminder of 2 huge studies with huge data sets that will become available in the course of next year. You've heard Martin gave the details of REMOX. Just a reminder, this, hopefully the final results will show a good alternate 4-month regimen in drug-sensitive patients. Regardless of the outcome of the primary endpoints, this is 1,931 subjects with both with liquid culture and solid culture, just an enormous treasure trove of data to look at how earlier time points, the time course of clearance of bacteria will predict later outcomes and relapse-free cure. And then also the off-the-tub phase 3 study, which, as Carl mentioned earlier in this meeting, huge amount of data, got stalled a bit by some challenges with the database. Now the database has been transferred to a new database, which is actively undergoing evaluation, and the results are expected by next summer. So again, 2 huge chunks of phase 3 data that will be available for the future. With that, I'll stop and thank you.